All right. Approach to the evaluation of the fetal venous system. Systemic venous system followed by the pulmonary venous system. So this is not an easy topic. I'm going to try to simplify it as much as possible. So we'll review some of the normal fetal venous anatomy. We'll show you a stepwise approach to the evaluation of the fetal systemic venous system, and we'll review some venous abnormalities. So, some embryology, we all started, well, maybe most of us, with a symmetrical system. So you have two cardinal veins, four actually, right superior, left superior, right inferior, left inferior cardinal veins. We have two umbilical veins, a right and left umbilical vein. We have two vitelline veins, a right and left vitelline vein, and we have the four pulmonary veins that are not shown on this schematic drawing here. So we go from a symmetrical system during embryogenesis to a system like this. And you can see the coloration actually determines what is the embryogenesis of these important elements in the systemic venous system. So this is replicated by this anatomical drawing where you could see the umbilical vein giving off the ductus venosus. This is the portal venous system coming off the umbilical vein. The IVC, returning blood to the heart. The hepatic veins. Coronary sinus, draining the heart itself. The four pulmonary veins. The azygous vein that Elena showed you in the prior presentation, the superior vena cava, and the left brachiocephalic vein. So that's the anatomy of the systemic venous system, putting it in one plane. And if you look sagittally, remember I showed you, here's the aortic arch in a sagittal view that is angled a little bit from right to left. And using sophisticated technology, this is the azygous vein coming in and bringing blood into the superior vena cava, as you see right here. You have the right atrium right here, and you have some of the drainage of the hepatic veins at this level here. So going back to the basics, at the abdominal circumference level, if you bisect the chest into two halves, you would see that the IVC is in the right half, and the portal sinus turns towards the right side of the fetus. The aorta, as I mentioned earlier, is in the left side. If you follow the IVC, actually, the lower you are in the pelvis, the IVC is more in a retroperitoneal space and moves more anteriorly as you go up into the abdomen. I'm going to follow this really very nice article that Dr. Sinkoskaya authored on the approach to the evaluation of the fetal venous system, primarily using the transverse planes that we are really very comfortable with. That's how we measure the abdominal circumference. That's how we look at the four-chamber view, and really relying primarily on the transverse plane to comprehensively evaluate the fetal venous system prenatally. So you have the portal and hepatic venous system will be evaluated through two planes, and I'll go into that in details, at the level of the abdominal circumference. The coronary sinus, as you have seen yesterday, is a plane that is slightly inferior to the four-chamber view. The pulmonary veins, as you know, are evaluated at the level of the four-chamber view, especially the two inferior ones. The azygous and the superior vena cava are evaluated at the level of the three-vessel trachea view. And the left brachiocephalic vein, as I've shown you yesterday during the presentation, the scanning, is a plane that is slightly higher up in the mediastinum, but still transversely. And then if you go into the parasagittal planes, you could see the IVC and SVC coming together. For the interest of time, I'm going to focus on these four imaging planes and actually to show you what's normal and what's abnormal. So what is the venous portal system? By definition, a venous portal system defines veins that don't go towards the heart. And there are two portal systems in the human body. There is the hypophyseal portal system, where the vein goes from the hypothalamus to the pituitary. And there is the hepatic portal system, where the veins go from the GI tract to the liver. And by design, these pathways in the GI tract are designed to really make sure that all the GI blood that is from the food we eat goes through the first pass through the liver to be cleaned before it goes into the systemic circulation. From the hypothalamus to the pituitary is for the hormonal sequencing of what the pituitary is designed to do. Now I want to share with you the blood flow to the liver. If you look prenatally, the liver has three sources of blood flow. The placenta, through the umbilical vein, is the main source of blood flow to the liver, right? The umbilical vein becomes the portal venous system. You have the aorta, through the hepatic artery, directly bringing blood flow to the liver. And you have the GI tract, through the main portal veins, bringing blood flow to the liver also. And the size of the arrows really determines the amount of blood flow that comes to the liver prenatally. So about 75% of the blood flow to the liver comes from the umbilical vein prenatally. About 25% comes from the hepatic artery, from the aorta. And a very minuscule amount comes from the main portal vein that brings blood from the GI to the liver. And then the drainage of the liver is through the three hepatic veins that drain into the IVC. Postnatally, what happens, there's no umbilical vein anymore, right? So the main blood supply to the liver is through the main portal vein from the GI tract, supplemented by flow from the hepatic artery. And drainage of the liver postnatally is the same process as the three hepatic veins that drain the liver into the inferior vena cava. So with this information, let me show you a schematic drawing now prenatally, and let me see if I can show you this. So here's the umbilical. First of all, let me start with the aorta. The aorta gives rise to the hepatic artery, is a direct branch of the aorta that brings about 25% of the blood flow to the liver. The umbilical vein, coming from the placenta, brings 75% of the blood flow to the liver and divides, and I'll go through the anatomy of the umbilical vein in a minute. And then you see in the background, you have the splenic vein, the mesenteric veins and others that coalesce together to form the main portal vein that brings a little bit of blood to the liver prenatally. The drainage of the liver is really through the left, mid, and right hepatic veins into subdiaphragmatic vestibulum that goes into the right atrium. And here you see the ductus venosus connecting the portal venous system to the hepatic venous system in the fetus prenatally. And this drawing here shows you the various components of the main portal vein from all the organs in the GI tract that coalesce together to form the main portal vein. And this is a schematic drawing showing you the drainage of the liver by the three main left, middle, and right hepatic veins, as you see here. Postnatally, the umbilical vein closes, so the main portal vein now becomes really important, and the circulation is reversed. You see the blood flow then comes to the liver through the left portal vein and the right portal vein, as you see here. The drainage is the same. If you look at the fetus in a sagittal view, here you have the umbilical vein coming in, and here's the portal sinus as you see. So that is the portal venous system, and the drainage of the liver is by the hepatic veins. And here in this view, you see the middle hepatic vein, and that's the hepatic venous system. You see how they are in two planes. One is at the level of the umbilicus, at the perfect level of the abdominal circumference. That's the portal venous system. And then if you slide slightly up under the diaphragm, you get the hepatic drainage. The connection between the two is the ductus venosus. The ductus venosus shoots a little bit upward towards the subdiaphragmatic vestibulum. And here you see on this drawing and this corresponding ultrasound image, so here you see when I am at the level of the umbilicus, this is the abdominal circumference. You have the hepatic vein, umbilical vein coming in, turning into the portal sinus. So here you have the umbilical vein. That is the portal sinus here. This umbilical vein gives rises to three branches, middle, inferior, and superior. That turns into this area called the right portal vein, anterior and posterior, and you see the ductus venosus here. If you go a bit higher, right under the diaphragm, you see the left, middle, and right hepatic veins draining into the IVC. So these are the two planes that you're used to looking at when you do abdominal circumference and add color Doppler to. So the left, by definition, the left portal vein is, as soon as the umbilical vein enters into the abdomen, this area is called the left portal vein. That includes the portal sinus also. Has three branches, middle, inferior, superior. It turns into the portal sinus, and that's classically called the right portal venous system. Has posterior and anterior branches. And you see the ductus venosus here. And the main portal vein is coming behind, as you see right here. So that's and it looks complex, but let me show you what you see on your abdominal circumference. So if you add color, you'll see the umbilical vein coming in. Look at the three branches, 1, 2, 3. Inferior, superior, and medial. These are the left portal venous system. Look at the ductus venosus coming out here. That is the portal sinus, and you have two branches here, anterior and posterior. That is the right portal venous system. In this plane, you don't see the main portal vein because it comes from under the liver in this particular fetus. Left, right, ductus venosus. The main comes under. If you go a little bit higher under the diaphragm, then you have the hepatic drainage, the three hepatic veins. Here you have the left, the middle, and the right hepatic veins draining into the IVC and the subdiaphragmatic vestibulum. And if you do 3D, you can see both systems, umbilical vein and ductus venosus. Here's the three hepatic veins draining, and there will be the portal sinus right around this area right here. So this is the normal anatomy in the abdomen of the venous system. Complicated, but actually if you just review it at your own pace, you'll see it's not really that difficult if you know where the left portal venous system, the right, and where the hepatic drainage of the liver is. So I'm going to go through this long list of abnormalities fairly quickly. Let me start by the first one, a persistent right umbilical vein. The definition of a persistent right umbilical vein, remember when I said embryogenically we had right and left umbilical veins, and then the right umbilical veins disappears and we end up with the left umbilical vein? But it's very confusing because that left umbilical vein curves towards the right side as a portal sinus. So a left portal vein and a sinus that turns to the left side, as you see right here, instead of turning to the right side, if it turns towards the stomach, and the gallbladder is to the inside of that, as you see right here. So that's a persistent right umbilical vein. So here's the criteria for diagnosis, and you see the schematic drawing here. Here's another fetus with the same persistent right umbilical vein, and look where the gallbladder is, right under to the left side of that. So this left persistent umbilical vein, it could be a normal variant. In a large series, most of the babies are normal. It's important to do a detailed ultrasound when you see this abnormality. Look at the heart and more carefully. There's some debate whether you need a fetal echo or not. Probably a detailed ultrasound would suffice. And certainly a follow-up ultrasound once or twice. Next is the umbilical vein varix. What this means is just the dilation of the intra-abdominal extrahepatic umbilical vein, meaning the umbilical vein is dilated before it really enters the liver. It looks like it's inside the liver, but it's actually right on the outside. And you could see on color Doppler how dilated. There's always aliasing in here, as you see. There's some criteria for diagnosis. Some people used more than 9 millimeter or more than 50% of the intrahepatic segment. So that's the intrahepatic segment here. If this is more than 50% of that, that's a diagnosis, or simpler to use more than 9 millimeter. Or visually, you can inspect it to see it. There's a correlation with fetal growth restriction and demise in some large series. So here's look how big that one is, clearly. So recommendations is detailed ultrasound, follow-up probably every 3 to 4 weeks looking for fetal growth restriction. Depending on the size, decision for fetal surveillance. If the size is really large, Certainly looking at markers, cardiac markers of fetal stress or non-stress test, twice a week or biphysical would suffice. If you look at this abdomen in grayscale, you see there's this mega cystic structure in here. Is this a varix? Color Doppler is really helpful because this is just a large gallbladder, humongous gallbladder. Okay, so next, let me show you the important connections of the umbilical vein. So the umbilical vein, if you follow the umbilical vein in a normal fetus, let me enlarge this segment here. You see that the umbilical vein enters the liver, and then there's an angle that shoots towards the heart where the ductus venosus is. And this is the umbilical vein, that's the angle for the ductus venosus. There are many abnormalities that could happen between the umbilical vein and the ductus venosus. So here's the normal drawing. Here you see there's no ductus venosus. Here you see the ductus venosus is going straight into the IVC. Here there's no ductus venosus, the umbilical vein going straight into the IVC or to the heart or to the iliac vessels. And here's some corresponding examples. I'll show you two examples, recent examples that we had here. The importance of this is there's an association with genetic abnormalities when you see this. There's some association with fetal growth restriction, especially with agenesis of ductus venosus. In the first trimester, there's some association with aneuploidy. And there's 4 fetuses with different genetic abnormalities with abnormalities of the ductus venosus attachment. Here's an example where the umbilical vein comes in and goes into the pelvis. And it is the iliac vessels. You could see the trajectory of this. And if you look at the IVC would certainly be massively dilated because you have all the extra blood going inferiorly. And here's another example where the umbilical vein is actually going into the heart, straight into the heart and not going into through the ductus venosus into the IVC. And here's another example again. You see the umbilical vein coming into the heart. So these are important to look for. Again, associations, fetal growth restriction, evaluation, detailed ultrasound, and so forth. Let me move into the portosystemic shunt. What does this mean? Remember, there's a systemic venous, right? That's the drainage of the liver into the right, middle, and left hepatic veins. And there's the portal venous system. So any direct communication or a fistula between the portal venous system and the hepatic venous system is called the portosystemic shunt. Because if you think about it, the blood coming from the GI tract should go inside the liver tissue to be cleared before it is absorbed into the systemic venous system, into the heart. So any direct connection creates a portosystemic shunt. It could be extrahepatic. These are typically involving the main portal venous system. I'm not going to discuss those. Or intrahepatic. So what does this mean? Here's a normal anatomy that I've showed you earlier. So what happens here is the blood comes in from the placenta, is disseminated into the liver tissue through the left and right portal venous system, and the drainage from the liver tissue goes through the right, middle, and left hepatic veins. Yeah? So when you have a communication between the left portal venous system and the left hepatic system, this is called the portosystemic shunt. It could be between the right venous portal venous system and the right hepatic venous. You can have an extra, I'm not going to go through the extra hepatic, this is a bit more complex, and it's rarely we can identify them prenatally because the main portal venous system is so small. So let me go to the intrahepatic ones. So this is the most common, where you have a communication between the left portal venous system and the left hepatic venous drainage. So what you will see on ultrasound, here's what you will see. The umbilical vein coming in, and there's these huge branches of the portal venous system that are draining into the left hepatic venous system, you see. And this is where the fistula is, right around this level here. So the way for you to make this diagnosis is you look at your abdominal circumference, you turn color on, and there's these humongous vessels that don't belong there. That is more likely than not a portosystemic shunt. Okay, and you see here the branches of the portal venous system. This is the left inferior, left superior, and this is the left hepatic draining the blood directly through this fistula right here. Because this takes away blood from the liver tissue itself, because now there's no portal venous system on the left side that's going into the tissue, then the hepatic artery compensates from the fetus. So if you look at the hepatic artery on a sagittal view, you will see that the hepatic artery is maximally dilated. Look at the size of this hepatic artery coming out of the aorta. Because remember, the left venous, portal venous system is not really supplying the liver with any blood anymore because it's draining directly into the hepatic drainage. Here's a right communication between the right portal system and the right hepatic vein, as you see right here, and you see it here on the still image. And look what you see on grayscale, dilated vessels. Why these are important? Because remember, postnatally, this blood is not cleared anymore by the liver. So these newborns are at increased risk for hepatic tumors because this blood has a lot of markers in it. Intestinal vasoactive mediators can lead to pulmonary hypertension because they're not cleared by the liver. And then you end up with raised ammonia levels in some of those fetuses that end up with encephalopathy and other complications. In our experience, the ones that have poor prognosis, and this is just on personal observation, if you have any cardiac or extracardiac associated abnormalities, if you have fetal growth restriction, any decrease in the normal portal venous system, if you see that the liver is not getting enough portal venous system or any flow and increased flow in the hepatic, are typically associated with like a guarded outcome. So that's what a portosystemic shunt is. Really at the base level, at your abdominal circumference, if you turn color on and you see these large vessels, investigate for the presence of portosystemic shunt. That's the easiest way to make that diagnosis. There was some discussions. Michela showed you nice images on the left brachiocephalic vein. So this is a vein that is in the high upper mediastinum. You see it above the aortic arch. You see the schematic drawing here, right here, at the borders of the thymus gland, and you see it right here. And you see a portion of the aortic arch when you look at this. And here's an autopsy specimen where you have the jugular veins and the subclavian veins are highlighted. Here's your left brachiocephalic vein that's dumping blood into the SVC. Remember, we had the left and right subclavians, and the left subclavians does not develop in embryogenesis, and we end up with only one subclavian vein. And here you see on color Doppler the blood flow that is going from left to right because it's taking blood from the left side of the head and neck into the right side through the superior vena cava. So abnormal findings of the left brachiocephalic vein could be absent, persistent left superior vena cava. I think Michelle had shown you that. Could be dilated. Here you can have either a supracardiac total anomalous venous return or a vein of Galen aneurysm or any AV malformation in the brain with the results in an increased flow. Or you can have an abnormal course. It could be inside the thymus gland, it could be under the aorta, or it could be behind the trachea. These are really certainly quite rare. So let's look at a persistent left superior vena cava. So the classic view is the three-vessel trachea view. Superior vena cava here, aorta, PA, and the left superior vena cava. Note that the left superior vena cava is not at the level of the superior vena cava. The right superior vena cava is a little bit more posterior. It's more at the level of the trachea. Okay? When you turn color Doppler, and this is really important, and Michela showed you that very nicely, the blood flow should be in the same direction as the superior vena cava, right? They are both bringing blood from the head and neck into the heart, right? That's really, really important. And then what you will see, because the left superior vena cava drains into the coronary sinus, then the coronary sinus will be dilated. And you see here the coronary sinus at the border of the heart. And in the four-chamber view, if you go a bit inferiorly, you may erroneously think this is an AV canal. It's actually just because the coronary sinus is dilated. And remember, the coronary sinus is in plane slightly inferior to the four-chamber view. And here's another example of a really dilated coronary sinus here. And the blood flow in the coronary sinus will be from left to right, as you see right here. And here's a 3D rendering of the heart with the left and right, and you can see the left superior vena cava coming into the borders of the left atrium here, and the right supravena cava on this side. When you have a persistent left supravena cava, you do not have a brachiocephalic vein, right? Because there's no need for a bridge that takes blood from the left to the right anymore, because the left is draining all the way to the heart. Now, left supravena cava, remember I showed you a 10% association with tetralogy of Fallot, but there's an association with interrupted aortic arch, with an aortic coarctation, double outlet right ventricle, and right aortic arches also. So when you see a persistent left supravena cava, you need to do a fetal echo to make sure that the heart is normal otherwise. When the left brachiocephalic vein is dilated, as you see right here, look at the size of this left brachiocephalic vein here. Think about, as I mentioned, any AV malformation in the brain, such as this case of vein of Galen aneurysm in the brain that results in significant engorgement of the head and neck vessels coming down, and you could see the jugular veins, how dilated they are, and then results in a dilated right side of the heart due to the AV malformation, and certainly an enlarged brachiocephalic vein as part of that. The other association with the dilated left brachiocephalic vein is supracardiac total anomalous venous return, and I think that will be covered in the next talk. But here, what you look at, clues to the diagnosis, is you have a normal coronary sinus, because this is not a LSVC, a dilated left brachiocephalic vein, and the three-vessel trachea view will show an additional vessel, as you see right here, because this is the vertical vein taking blood from the confluent vein up to the brachiocephalic vein. But the key is of different color than the supravena cava, right? Supravena cava is bringing blood down to the heart. This is taking blood up to the brachiocephalic vein to come down the SVC. So it's in opposite direction of blood flow, and that's really critical in your evaluation. There are additional features, I'll pass those, that could help you in the total anomalous venous return. They will be covered in the next presentation. Finally, the abnormal course of the left brachiocephalic vein. This is the normal anatomic location at the borders of the thymus gland, as you see right here. And here you see it on grayscale imaging. And these are branches of the aortic arch here. But it could be intrathymic, meaning it courses in the middle of the thymus. We used to get a lot of referrals for that there's an abnormal vessel that we see in the mediastinum, and that's a normal variant, is not associated with any abnormality. So you see here's the thymus gland right here, and look at the course of this brachiocephalic vein right in the middle. It could be subaortic. I think I showed you a case today with the tetralogy of Fallot case, and it could be retrotracheal, as you see right here. So these are quite rare. Most of the ones that we see are intrathymic. And you can have a double left brachiocephalic vein in some rare situations. When we looked at the data from both centers, our centers and Dr. Shawi's center in Berlin, we found the incidence of intrathymic left brachiocephalic vein in about 1.7%, and double and absent was extremely rare. Briefly interrupted IVC. Elena had shown you very nicely the interrupted IVC in association with the left isomerism, as you see here, where the azygos vein will be parallel to the aorta in this view. And you can see it in the area behind the heart, as you see right here. And here's a normal 3D rendering showing you the aorta and the IVC. And in a fetus with an interrupted IVC, you see the dilation of the azygos in parallel to the aorta here. And this is in your syllabus. This is really important to know the relationship of the IVC and the aorta with regards to right or left isomerism. And this is for you to review to see that. So, venous malformations, clues to diagnosis. Remember to look at the liver, any dilated veins, especially the presence of collary aliasing. Think about portosystemic shunts. Think about, abnormal course of the umbilical vein, or think about umbilical vein varix. IVC, look at the interrupted IVC. Remember its role in left isomerism. A dilated azygos or hemiazygos is related to that, and look for it. And then the left brachiocephalic vein, absent and persistent LSVC, dilated and total anomalous venous return, or other AV malformations in the brain. And most of the time, the abnormal course is just a normal variant. All right, thank you.